Next up, we're going to have Dr. John Shippo. Dr. Chabot is absolutely one of the world's best pancreas surgeons. I have to say, if I personally ever needed my pancreas operated on, I'd be going to Dr. Chabot. And he's had the vision to establish here at Columbia a world-renowned pancreas center that deals with many, many different subspecialties, research programs, all centered around the pancreas. So I'm really glad to be able to have him here tell us about the pancreas manifestations for VHL.
Well, thank you, Wendy. That may be the best introduction I've ever had. Okay, so there is a pointer. I'm not Jeff Bruce. I'm not tall enough to reach the slides, so I'm going to use the pointer. Good news about VHL and the pancreas. The vast, vast, vast majority of problems we see in the pancreas really don't affect the person, don't need intervention. Many of them don't need to be followed. So if you're thinking about pancreatic cancer the way most people think about pancreatic cancer as a horrible, terrible disease that we rarely cure, that doesn't happen with increased frequency in people with VHL. So we're not talking about classical pancreatic cancer. What does happen to the pancreas in people with VHL? People develop cysts, as has been described in the other organs. Cysts are really just sacs of fluid with a set of lining cells around that sac. I usually describe them as water balloons to people. And it's the cells that line the inside of the water balloon that we have to think about. As Dr. McKiernan pointed out, cysts in the kidney can turn into kidney cancer. The cysts we see in the pancreas in VHL do not turn into cancer of any type. The cysts can grow, the cysts can interfere with function rarely, but it's not a cancer risk of any sort. The other thing that develops in people with VHL is this entity called serous cyst adenoma. Again, a completely benign lesion. Same thing, if they get big enough to distort function, if they irritate the pancreas, if they irritate surrounding organs, we might need to do something about that, but no cancer risk whatsoever. The third on the list here, neuroendocrine tumors of the pancreas. By and large, in people with von hippel-lindau, the pancreatic neuroendocrine tumors are benign and usually remain benign, but they do have malignant potential. So those are the ones that we have to pay attention to in VHL. The malignant potential is nowhere near as evil as what people think about as pancreatic cancer. So we always refer to these as neuroendocrine tumors to take away some of the stigma, to take away some of the fear that arises if you attach the word cancer to it. So where is the pancreas? This is the middle of the body. The rib cage is about here. The large intestine is here. The stomach is here. The pancreas sort of runs across sideways in the back of the abdomen in an area called the retroperitoneum. You can see that this is actually the very, very center of the body, and it turns out that the pancreas is truly the seat of the soul. How do we find tumors of the pancreas? CT scans or MRIs, unlike the kidney, the regular kind of ultrasounds we do from outside of the body through the skin generally are not accurate enough for us to diagnose lesions of the pancreas. So we do need to resort to CAT scans or MRIs. If we see something that we're worried about on a CAT scan or an MRI, there is a technique using ultrasound that's done from inside the stomach. It's a little ultrasound probe that's attached to the end of an endoscope, which is passed through the mouth down into the stomach. And the pancreas is about an inch away. So we get extremely accurate pictures, and biopsies can be done using that technique. And far and away, the most common way we biopsy the pancreas is by endoscopic ultrasound. Luckily for me, kidney tumors are far more common, so I'm usually riding on Dr. McKiernan's coattails, and I just look at the scans that he does, and we can screen the pancreas that way. Overall, about 75% of people with VHL will have a lesion in their pancreas. So we do need to look, but again, the vast majority of those are those simple cysts that don't need any particular attention. So this is what a pancreas looks like on an MRI scan. Right there, running across the side to side. There's the spleen, there's the top of one kidney, so you can get a sense of where the pancreas is. And this is a patient with VHL who has very mild manifestations in the pancreas. Here's the pancreas. There's a cyst, there's a cyst, there's a cyst. Very, very mild. This is a more typical pancreas in somebody who has issues with the pancreas in VHL. You can see that the pancreas is big. It goes from there to there. And a great deal of it contains these cysts. All of those dark blobs are cysts. Again, we don't need to worry about this. It looks crazy worrisome. It's not. This is somebody we really don't even have to pay too much attention to because there are no pancreatic neuroendocrine tumors in that pancreas. So whatever Dr. McKiernan gets a scan, I'll look at it, but I don't need more scanning than that. This is a pancreatic neuroendocrine tumor, right there. And this is a pancreatic cyst. So the way we pick up these pancreatic neuroendocrine tumors is that this one is the contrast view, and this one is a special setting of the MRI called a T2 that tells us that that's a fluid-filled structure, and the brightness over on the upper left tells us that that tumor has a lot of blood vessels in it because that's the contrast agent that was given. We really do need those contrast agents to be able to see these things clearly and diagnose them clearly. And you need a really good radiologist to pick that out of the pancreas that has a zillion cysts in it. So we don't worry about the cysts. We don't worry about the serous cystadenomas. We keep an eye on the pancreatic neuroendocrine tumors. And just like Dr. McKiernan was saying that we in the pancreas world have learned a lot about pancreatic neuroendocrine tumors from people with von hippel-lindau because it was originally the von hippel-lindau group where observation was considered acceptable. And that has grown into a much wider paradigm where we as pancreatic surgeons are watching people without von hippel-lindau who have small pancreatic neuroendocrine tumors, whereas even 5-6 years ago, and even today, a lot of surgeons around the country will operate on small, innocent pancreatic neuroendocrine tumors. So thank you for teaching us how to take care of the rest of the world. So this is just an editorial I wrote a few years ago trying to convince the pancreas world that we really don't need to take out pancreatic neuroendocrine tumors in general if they meet criteria, if they're small. And because this is sort of a paradigm shift, we're not using the 3-centimeter number that Dr. McKiernan used in kidneys, but we do generally use the 3-centimeter number in people with von hippel-lindau. Ki-67 is a biopsy finding that tells us what percentage of the cells are multiplying. How actively is that tumor growing? And if only a very few of the cells are actively growing, we consider that a safe tumor to watch. And if people don't have symptoms, just like in the brain, we use symptoms to guide our interventions. So in VHL, as in the kidney, much of our guidance about what to do and how to be more conservative with surgery has come from the very large series of patients followed at the NCI. This paper was published in 2007, and it included observations on 633 VHL patients. 108 of them had pancreatic neuroendocrine tumors. Various series range from somewhere 8-9% to up around 20%. So I usually think about the likelihood of a pancreatic neuroendocrine tumor in a VHL person as around the 15% number. The risk factors that were identified to put people at risk for metastatic disease, the only way we know these tumors are malignant is if somebody shows up with a site of spread, a metastasis outside of the pancreas from the original tumor. Number one, very few people did develop metastases, but the risk factors were greater than 3 centimeters, a doubling time of greater than 500 days, meaning you can see the rate of growth on serial scans. And if the tumor is going to grow, double its size in under 500 days, that's a more worrisome tumor. If it takes more than 500 days to double the volume of the tumor, that's a less worrisome tumor. The newer way of asking that question is with that Ki-67 number on the biopsy. And then finally, which of the various mutations, almost all of the patients that they identified in this series who developed metastatic disease from their pancreatic neuroendocrine tumor had an exon 3 mutation. So those are the people that we pay particular attention to. So the answer about the pancreas then is don't be scared. If you have a problem with the pancreas, it's not going to be pancreatic cancer. The vast, vast, vast majority of people never need an intervention on their pancreas in the setting of VHL. And if somebody proposes taking half of your pancreas out, find somebody else to confirm that that really needs to be done. Thank you.